Well, GIS, thank you and congratulations. I chose to present two short cases, going through them very quickly. The first case is a 49-year-old heavy smoker who sustained an inferior myocardial infarction 3 weeks before I saw him. And at that time, he was taken to an outside of Jordan hospital where he had a primary PCI. At that time, they wired the vessel, which was totally occluded. They could not achieve TIMI-3 flow. For whatever reason, a stent was implanted, and again, that did not regain the flow. The patient was sent to the CCU and was left on intravenous tirofiban, enoxaparin, added, of course, to the dual antiplatelet therapy. His course there was complicated by bradycardia. He needed a temporary pacemaker, and he developed AFib in the CCU. 2 days later, they brought him back, looked at the RCA. It was still totally occluded, probably the stent area. And they tried again to wire through it and do angioplasty and regain flow, and that did not work. The patient came to me 3 weeks later. His echo showed a 45% ejection fraction with an inferior basal akinesis. And he had a dyspnea and exertion, not really chest pain. I put him on the treadmill, and there was a significant ST depression there with the dyspnea. So the dyspnea was his angina equivalent, obviously. He was maintained at the time when I see him on apixaban, clopidogrel, aspirin, and beta blockers, and statin. So I took him to the cath lab, radial approach. This is the right coronary artery, which was intervened with. And if you look in the area in here, there is a shadow of the stent, which is not easily seen. If you're wondering about the left side had minimal ectasia in the mid part of the LAD with some collaterals to the RCA, which are not excellent collaterals. So what did I do? Of course, after wiring through the area there, I did a lot of angioplasty, and I didn't want to show it to you just for the sake of saving time. And that's what I got here. Big type of filling defect here with a lumen, but the lumen distally seems to be very true lumen. You know, you look at it here, it's the PDA, and there's a myocardial blush there. So I wasn't sure exactly what was that. And looking at it again, if you have very good eyes, you probably can catch it. But anyways, I did some angioplasty distally, and then came to the rescue doing a stent boost. Stent boost is a wonderful thing to have in the cath lab, definitely. So that told me what happened. So my wire was actually what I would have thought is outside the stent. Well, was it really outside the stent, or was I in the 2 lumen? Was that stent actually put in from a 2 to false lumen? I wasn't sure exactly what happened with them before the patient came to me. So I was not really sure what the etiology is. So what did I do? I did multiple wiring. You know, I put these 2 pictures, which is actually a 45 minutes to an hour work, trying to wire into the stent itself, and I could not. So I had to make a decision. So I made a decision. So I said, well, what's the point of not crushing that part, irrespective of what happened? So I put a long stent and another long stent, and that's what I got. You can appreciate, let me go back to that one which I went through quickly. You can appreciate the stent over there in the shadow, in the back there, which is crushed before putting the second stent. So I did 2 stents inside that stent, made sure that I'm going from a 2 to 2 lumen, which I think I succeeded with, and the flow was not bad at all when the patient left the cath lab. The patient remained stable, ejection fraction improved to 55%, and we called him. He's from outside of Jordan, even before I came here, and he's still very stable and leading normal life. So I learned a lot. It's actually, sometimes you have to make those decisions in the cath lab. Would IVES have helped? I'm not sure. I think the stent boost gave me the whole solution of what to do. And the crushing the old stent was not a bad idea at that time, and that led to a good outcome of our patient. Utilizing CTO techniques is quite helpful. Getting familiar with the subintimal, interplaque, and subadventitious stenting is important. And please remember, this is a patient, he is not an outpatient because, that's beyond 72 hours, yes, but he had symptoms and a positive treadmill. My second case is a late STEMI patient with a twist again. This is a 53-year-old who is a heavy smoker on no medications, came in with ST elevation myocardial infarction about 11 o'clock at night. I did an echo quickly. He had a 45 to 50% ejection fraction with inferior hypokinesis. Took him to the cath lab, did radial approach, of course, and you can see the little trickling of dye here in the totally occluded proximal RCA. But remember, he came in very late. So he came in more than 24 hours of the onset of chest pain. And you can appreciate, if you like a bridging, this is really a bad bridge in the LAD in the mid part. But anyways, so I did wiring, a lot of ballooning and massaging the artery, did not get a lot of good flow. So I put an aspiration catheter multiple times, tried to suck whatever clots are there out. And I did not get anywhere quickly, so I put a microcatheter and high-dose adenosine and adrenaline distally until I started getting a better flow. Excuse me. So I decided to stent that mid part of the RCA, which I did, and I gained the flow. It's not bad at all. At the crux area, the flow is not the best. And you can see there's some filling defect proximal and distal to the stent again. I tried to put the aspiration catheter multiple times. I was met with resistance, and that did not work. So anyways, I decided, after, again, marinating the distal part with high-dose adenosine through a microcatheter, to put another stent. So I put another stent proximally, ballooned it, and, of course, the question which came to my mind is, I want to make sure that the stent is inside the other stent, so I did the stent boost. I like stent boost, obviously. So that told me that I am inside the stent, I'm in a good position. But you look here at the distal part of the stent there, you can see that there's some kind of funny thing there sitting, right? You can appreciate that as if the stent was not totally expanded. So I took a picture with the proximal and distal stent in place, and I realized that my first stent, if you remember the image, was fully deployed. The balloon was very good. It was obviously fully expanded. And there is some kind of funny thing compromising the lumen there in the first stent I put. So what did I do? I tried multiple times, another hour spending, to get a wire in that area, and that was not an easy task at all. And finally, I got it in, and I got a 1.2 balloon because no other balloon can go through it until I got it. And then again, to my luck, I looked after I put the small balloon with another stent boost. So I'm a stent boost man, you can call me today. So look what happened here. In the middle area where the older stent was, there is a deformity. There was a big deformity. You can call it a longitudinal type of deformity. You can call it accordion defect. But the stent was deformed, obviously, by the previous attempts to put the aspiration catheter in. So after multiple attempts, I managed, and I put another stent in, which solved the problem. So this led me, and I did another stent boost for a final imaging, and you can see the beautiful, well, it did cost me, I have only one slide to go. It did cost me, obviously, another third stent, but it worked out in this patient with late STEMI myocardial infarction. Can I put the last slide, please, or just the last slide? Well, anyways. So again, I learned a lot from this case. First, utilizing simple images like stent boost in the cath lab can get you out of a dilemma there and tells you what's going on. It really goes without saying, when you interfere with late STEMI patients, don't expect their clots to be like a jello. They're usually tough to deal with. And when you get slow flow, please remember, don't deliver it simply intercoronary. Just use always microcatheters to do it distally. And remember, longitudinal deformity of the stent can happen, even in the mid vessels rather than only in the ostium. Thank you very much.